Hi everyone, my name is Med2Med. This video is going to be about hyperprolactinemia, a phenomenon that can affect both men and women and is a very important endocrine condition. These notes, as usual, are based on the following resources. I've been looking through Scott's notes to make some concise guidelines, the Oxford Handbook of Clinical Medicine, and also looking at what NICE recommends. As always, a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. Okay, first let's go over what prolactin is. It's also known as lactoprotein, and it is secreted from the anterior pituitary gland in response to eating, mating, estrogen treatment, ovulation and nursing. It's a really important hormone and it's the trigger for lactation, but also plays an important role in regulating the immune system. Let's go through the pathway in which prolactin acts. The red arrows are inhibitory signals and the black is stimulatory. So as you can see, dopamine is produced in the arcuate nucleus of the hypothalamus. This stops prolactin from being released. However, thyrotropin-releasing hormones and vasoactive intestinal polypeptides, that's VIP and TRH, stimulate prolactin secretion from the anterior pituitary, which is then cleared by the kidneys. You can also see the different ways this can be affected on the right-hand side of the diagram. This alludes to the sort of things which might cause hyperprolactinemia. Did you know hyperprolactinemia is actually the most common hormonal disturbance of the pituitary? Prolactin decreases your levels of sex hormones. So in women, they will have low estrogen, and in men, they will have low testosterone. This is how the ovaries and testes release estrogen and testosterone. As you can see at the top, gonadotropin-releasing hormones are released from the hypothalamus, that's GnRH. This then stimulates the anterior pituitary to release FSH and LH, which are the gonadotropins, hence the hypothalamus's hormone's name. This then stimulates the ovaries and testes and causes the release of estrogen and testosterone. However, prolactin actually tends to suppress this GnRH secretion that we've mentioned from the hypothalamus, and in turn, of course, this will then decrease the FSH and LH and prevent the release of estrogen or testosterone. Now we understand this, we can go through and explain why some of the symptoms manifest due to this lack of estrogen or testosterone. In women, they may have very few or even absent periods. Because of this, they might have fertility issues. They may experience lactation, a decrease in libido, weight gain, and a dry vagina, all because, as we've mentioned, there's this decrease in estrogen. Then, in men, they can have erectile dysfunction, decreased facial hair, galactorrhea, and even present with late osteoporosis or pressure effects from the tumour that's causing this hyperprolactinemia. So that's a hint where this hyperprolactinemia can actually come from. Often, it presents earlier in women due to this really clear menstrual cycle disturbance, but later in men, so that's with this erectile dysfunction, the mass effects, osteoporosis as we've mentioned. The causes can be split into three mechanisms. There's excess production from the pituitary via a prolactinoma. So remember, we've mentioned prolactin is being released from this anterior pituitary. So if you have a tumour that's going to be releasing those hormones, the prolactin will increase within the blood. If there's disinhibition, so that's for instance by compression of this pituitary stalk we've seen, this will in turn reduce levels of dopamine and then stop the inhibition of prolactin. So rather than stimulating the release, it's actually blocking the thing that usually prevents prolactin from being released into the body. Lastly, if you use a dopamine antagonist, this again will stop the prolactin inhibition. Dopamine normally inhibits prolactin, So if you're blocking dopamine, again, similar to the second mechanism we've mentioned, it's going to stop prolactin inhibition. Then we can look at the causes in terms of physiological, drugs, and disease causes. So firstly, under physiological, we have pregnancy, which of course will naturally increases prolactin because obviously we're breastfeeding, we're lactating, there's stress as well. Drugs like metoclopramide, which is a dopamine antagonist, we've mentioned this is one of the mechanisms, and haloperidol, which is an antipsychotic. There's also methyl-dopa. Estrogens, again, work similar to how it occurs during pregnancy. Some illicit drugs like ecstasy and MDMA, and other antipsychotics. Remember, this is all inhibiting the dopamine pathway. Then, diseases that can cause raised prolactin levels are things like a prolactinoma, stalk damage via pituitary adenoma, it might be surgery, trauma, or hypothalamic disease. We learned that thyrotropin-releasing hormone stimulates prolactin. Remember, we saw at the beginning there's this TRH and it's stimulating the prolactin secretion. So, in hypothyroidism, because the thyroid isn't working correctly, the body's trying really hard to stimulate the thyroid, releasing this thyrotropin-releasing hormone. So, of course, this is going to be increased and the prolactin is going to be increased in turn. Lastly, chronic renal failure is because we know that prolactin is cleared via the kidneys, so if there is poor renal clearance, there's going to be poor prolactin clearance. We spoke about prolactinomas, which are tumours of the pituitary gland. They can be small, so that's a microprolactinoma, which is less than 10 millimeters on MRI, or big, a macroprolactinoma, which is greater than 10 millimeters on MRI. Of course, we're now going to want to measure the prolactin levels if they're getting these symptoms. In women, we're also going to want to do a pregnancy test because we know this naturally raises the levels of prolactin. So we don't want to go down the route of investigating if there's some sort of pathological disease that's causing raised prolactin when really the woman could just be pregnant. Again, we spoke about how hypothyroidism increases thyrotropin-releasing hormone, in turn increasing prolactin. So a thyroid test is really important to do. Using these, again, we've mentioned the renal clearance of prolactin, so you want to look into this. And you're going to want to do an MRI of the pituitary if all other causes are ruled out. So again, looking into this prolactinoma. We've mentioned that this is an endocrine condition, so then you should refer all of these patients to a specialist endocrine clinic. Okay. Exploring treatment, the first line treatment, again, we've spoken about how dopamine antagonists can cause raised prolactin. So if you're going to want to treat this, you give a dopamine agonist. So this is activating dopamine receptors, so things like bromocriptine or cabergoline. Okay, great. Here's the summary. We learned at the beginning that prolactin is secreted from the anterior pituitary in response to gonadotropin-releasing hormone from the hypothalamus. Hyperprolactinemia presents early in women with menstrual disturbances and late in men with erectile dysfunction, osteoporosis, or potentially mass effects. Dopamine directly inhibits prolactin release, whereas VIP and TRH both increase prolactin. Prolactin is renally excreted. So hypothyroidism, where there is high TRH, and chronic renal failure, where there is poor excretion, can both cause hyperprolactinemia. You should do a pregnancy test in women presenting with symptoms of hyperprolactinemia because, again, this could be a really simple explanation why they're getting galactorrhea, why there are these really high levels of prolactin in their blood. And lastly, treat it with dopamine agonists like bromocriptine or cabergoline.